Hey there, welcome to the last lecture in the therapy series. I advise you to start today learning a little bit about Dr. Collette Smart. She is a clinical neuropsychologist at the University of Victoria who recorded a little video for the university about some of her work and what she does and how she approaches therapy, and it'll be a nice table setter for this video, so look for the link to this in the description here. I'll just say for now that she's very interested in the possible benefits of other practices than talk therapy and pharmacology, things specifically like meditation. Other folks have looked into meditation-based intervention here. So in this case, there was a baseline group that just did regular treatment for their various, I believe, anxiety-based disorders, and then the second group did an 8-week study in meditation, in which they were intensively trained in mindfulness meditation, including a body scan method, a sitting meditation, and then a gentle form of yoga. And they were introduced to mindful eating and mindful walking. And so there were a bunch of different classes over the course of the 8 weeks, and they were taught sort of skills that they were supposed to carry forward. And then the researchers measured the group before the intervention and then measured the same group after the intervention. So we have their baseline scores and their post-intervention scores. And we see here a huge change in their scores on the Beck Anxiety Inventory, the Penn State Worry Questionnaire, and their profile of mood states, their, what else here, the Beck Depression Inventory, and the last one there, the Mindfulness Attention Awareness Scale. It makes sense that that one would increase a little bit, didn't increase significantly in this case though. So what that means to me is that while people might not feel that their general mindfulness has increased, the practice of mindfulness or meditation seems to do something pretty powerful to their experience of anxiety. So an interesting study to follow up on this one's from 2008, so someone probably already has, would be to have a look at how this kind of therapeutic intervention compares to other interventions like traditional cognitive behavioral therapy. And that's what I want to think about today. We're going to talk about alternatives to behavioral therapy. We've talked a little bit about pharmacology, talk a little bit more about that potentially as well, but I just want to give you an idea of some of the rest of what's possible out there. So one maybe I'm starting with the most intense, but some patients experience such severe depression that talking about it seems unhelpful, and in fact isn't helpful, and then even experiences with pharmacology can be unhelpful. And so some actually seek relief through electroconvulsive therapy. So this sounds ancient to us. It was started in the 1930s, actually. It wasn't even used on a person until 1938, so it existed for a long time. They were, I don't know, testing it on animals, I presume. So it works really quickly. It's not really clear why it works, but that aspect alone makes ECT kind of interesting to and potentially useful to clinicians, because if a patient, for example, is feeling suicidal and having thoughts of death, prescribing them drugs could take a couple weeks to kick in, but a quick instance of ECT could completely relieve those symptoms relatively quickly. Sometimes it's even the treatment of choice for pregnant women, because seizures don't seem to harm a developing fetus, but pharmacological psychotropic medications can. And the picture of electroconvulsive therapy in your mind probably isn't quite what it looks like anymore. The version of it in the 30s was definitely tough. People had lots of side effects to that process. These days, they only use electroconvulsive therapy in tandem with anesthesia and really powerful muscle relaxants, so that when people do go through, when they have the shock, when they have the physical convulsion, they don't hurt themselves and they don't feel anything negative. It is primarily used as a last resort, only in really intense cases, and isn't a long-term treatment for depression. There's a really high relapse rate and a need for repeated treatments, and in some cases people experience memory loss alongside, so another reason to only go to this treatment as a last resort. But it seems to be limited at least to the day of the treatment, but others, only a very small number of patients experience substantial memory loss. So again, treat this kind of thing with extreme caution. Give you an example of it via a TED Talk here. This is a really interesting story of a Connecticut surgeon who describes his own life-saving experience receiving electroconvulsive therapy and basically the history of it as well. So this is a really interesting video that I would show if we were in class together, but if I showed here, it would get my video taken down. So please follow along to that link and enjoy. Another type of treatment that sounds as scary as electroconvulsive therapy, but is actually a lot less intense, is called transcranial magnetic stimulation. So the way this works is electromagnetic coils are placed on the scalp, which transmit a pulse of really high intensity magnetism. And that rapid buildup and collapse of a magnetic field induces a momentary electrical current in the brain. It's not dangerous. It basically, what it does is create a really brief lesion. It's as if the part of the brain that was stimulated by the magnetic field didn't exist for a very brief moment. And it turns out that TMS over the left frontal lobe can result in significant reduction in depressive symptoms. You don't need anesthesia. There's almost no side effects. Some people sometimes experience headaches. So it's probably not quite a replacement for electroconvulsive therapy, but it is kind of similar in that you can really put away intense symptoms quickly by using it. It actually can also have some long-term positive effects. When patients have minor depressions that haven't responded to other medication, TMS sometimes is a useful procedure for them. So, another possible alternative treatment. Yet another is called eye movement desensitization and reprocessing therapy, EMDR. So the way this works is the therapist waves a finger in front of the eyes of a client, or has them watch, usually nowadays, something on a computer screen moving back and forth. The original idea was to unlock and reprocess previously repressed or frozen trauma memories. And there's not a lot of evidence of long-term effectiveness of EMDR, but there's maybe some placebo-type effects going on. But just sort of light exposure and the process of kind of going through that rapid eye movement seems to do something for some people. So there may yet be some evidence that eventually shows us exactly how it's effective. But for the most part, that evidence isn't super strong. But I started to say light therapy, light exposure does have an interesting effect in treating seasonal depressive disorder. So particularly in places where there's not a lot of sunlight during the winter, you'll see people have or go seek therapy from light exposure. You put a light that mimics sunlight really close to your face for a couple minutes in the morning. It can help people pull out of a seasonal affective kind of disorder. There's also surgery. Of course, that was the original solution for these kinds of issues, in which brain tissue is removed or destroyed. There used to be basically the only treatment at first was lobotomy, in which large parts of the brain are removed. It was the method to calm uncontrollably emotional or violent patients, in which they would sort of cut the frontal lobes from the emotion control centers of the inner brain. That has mostly been abandoned. Not mostly, it's entirely been abandoned, especially since the development of drug-based treatments for uncontrollable emotionality or violence. and psychosurgery in general is only used in really, really extreme cases. Sometimes when people have uncontrollable and intense seizures, or if they have a really severe OCD sometimes, but again, very rare, and again, really as a last resort. There are all kinds of different drug therapies depending on the issue the patient is having. So there are some antipsychotic drugs. Those typically are served to dampen responsiveness to irrelevant stimuli, which helps people experiencing things like auditory hallucinations and paranoia. You've maybe heard of Thorazine. Those have usually long-term side effects like involuntary movements in the face and in the mouth. Sometimes they have additional risks of obesity and diabetes. There's a class of anti-anxiety drugs that generally depress central nervous system activity. You've probably heard of Xanax, maybe Ativan. These have a strong tendency for psychological and eventually physiological dependence, but do tend to work somewhat. Antidepressant drugs, we talked a little bit about Prozac before. These are the SSRI kind of classes. They tend to change up the availability of norepinephrine or serotonin in the brain. Zoloft does this. Paxil is similar. They work really quickly in their effects on neurotransmitter systems, but the effect of them on actual thinking can take weeks, and that could be because their encouragement of serotonin passage from neuron to neuron promotes neurogenesis, so the patient needs to establish new pathways before their thinking can change. So that's why it takes a couple weeks, potentially. Again, these are the SSRIs. The older antidepressants had more side effects. All the weight gain, dry mouth, hypertension, dizzy spell stuff was primarily from older antidepressants, not so much used anymore. You've maybe heard of people taking lithium. It's a simple salt, which is sometimes an effective mood stabilizer for people experiencing highs and lows in something like bipolar disorder. It can lower the risk of death by suicide, but isn't super highly recommended, as I understand it. A lot of what some of these drugs do, particularly the antidepressant drugs, can be really heavily increased in their effectiveness by aerobic exercise. So there's an interesting sort of like the things that give you dopamine and promote serotonin passage or outside of the drug itself can also be really helpful. So that's kind of it. This is a short little video, a couple of different things outside all the specific treatments we've talked about and the types of therapy that we've discussed. So here's a summary of everything we've talked about. We did those specific treatments for phobias and OCD mostly, and depression. We talked about psychodynamic, humanistic, and cognitive therapies, and group therapy, these alternative electrical treatments, and now just a sort of quick run through of the biomedical stuff. So, hope you enjoyed. See you next time.